Welcome to the deep dive. This is where we take that huge pile of research. You've got maybe dense articles, surprising stats, clinical notes, even raw personal stories, and we really boil it down into clear, useful knowledge.
Making sense of complexity, that's the goal.
Exactly. And today's topic, well, it's one that absolutely demands objective clarity. We need facts here. We're doing an intense exploration into the medical concerns, the actual data on effectiveness, and the specific physical, sort of systemic harms linked to gender transitioning.
It's sensitive, but the details matter.
They really do. Our mission today is simple: to help you quickly, thoroughly, and importantly, objectively understand the real risks, the hard data, the long-term stuff involved in medical and even non-medical transition. We're sticking strictly to the statistics and consequences detailed in the sources you provided.
No speculation, just what the material says.
Right. And we're starting with something that kind of sets the stage, a real get-go. You shared research highlighting that a major UK medical institution did a huge review, looked at over 100 international studies on post-op transsexuals.
Yeah, systemic review, yeah.
And their conclusion, they found no robust scientific evidence that gender reassignment surgery is clinically effective. That's medically speaking.
Right. In its fullest medical sense, that's the physical journey. It often starts with puberty blockers for minors, then moves to cross-sex hormones, and then potentially various surgeries. The goal is to achieve the physical characteristics of the desired sex, whether that's male to female, MTF, or female to male, FTM.
Okay, let's unpack.
Male MTF or female to male, FTM.
Okay, let's unpack that pathway then. Starting maybe with expressions that don't involve prescriptions or operating rooms.
Sure.
Because lots of people express their identity without hormones or surgery. The sources mention simple things: choosing a name, cross-dressing, hairstyles, mannerisms, maybe voice training.
Yeah.
Specific physical harms if people try to physically alter their body shape without medical intervention, specifically binding and tucking.
Right. Those are the two main ones discussed.
Let's take binding first. That's common for biological females wanting a flatter, more masculine chest. Often involves what? Tight tape or special binders.
Exactly. Specialized fabrics, wrapped very tightly. And this can lead to some really serious acute problems, and chronic ones too.
Like what specifically?
Well, the sheer mechanical force involved is huge. It can potentially lead to broken or fractured ribs.
Wow.
And if a rib breaks badly, it could potentially puncture a lung or damage blood vessels nearby. We also see reports of spine injuries because the constant pressure changes how people hold themselves, their posture.
So it's about compression and restricting movement.
Pretty much. You're constantly squeezing soft tissue and stopping the rib cage from moving naturally when you breathe.
And the sources mention this isn't just immediate damage, right? There are long-term effects, especially for teenagers.
Absolutely. Female teams who bind while their chests are still developing often report ongoing, even lifelong chest pain, issues with breast tissue health later on, maybe permanent changes to how well their lungs work.
Permanent damage from something non-medical is the parallel practice for biological males called tucking. This involves hiding the penis, usually between the legs, and pushing the testicles up into the inguinal canals, sort of inside the groin area.
Right. And that has risks too.
Definitely. Focus on the urinary and reproductive systems. Constantly repositioning and compressing the urethra, the tube you pee through, can cause urinary trauma or lead to chronic infections, UTIs.
Okay.
Plus, it often causes painful testicular issues, maybe from compression, maybe friction, and significantly, it can lower sperm count. Mostly because the testicles are kept at a higher temperature than they should be, and because of the physical manipulation.
So even before we get to any drugs or scalpels, just these non-medical physical modifications carry documented risks for long-term harm.
That's the key takeaway here, yes. Real physical consequences.
All right, now we cross the line into actual medical intervention. And this seems to bring in risks that are, well, systemic. Those are GnRH agonists. Then that's followed by cross-sex hormones, which people usually need to take for the rest of their lives.
Okay, let's slow down here. Puberty blockers first. What exactly do they do?
Essentially, they press pause on the body's own hormone production. So testosterone in biological males, estrogen in biological females. The idea is to delay those secondary sex characteristics, deep voice, breasts, etc.
But the sources highlight a huge consequence right away.
Yes. The first immediate and totally irreversible outcome when you follow blockers with cross-sex hormones is sterility, infertility. Whether a young person goes from blockers to hormones or an older teen starts hormones directly, they become sterile. They can't have biological children later.
That is a massive trade-off, especially when these decisions might be made for young people whose bodies, and maybe brains, aren't fully developed yet.
It's a profound consequence. It's not the only developmental issue. Think about bone health.
Right,
Think about bone health.
you block the natural hormones. What does that do to bones?
Well, those natural surges of testosterone or estrogen during puberty are absolutely essential for building peak bone density. If you block that, you risk lifelong problems with skeletal health.
Like osteoporosis later on.
Exactly. The sources suggest people who go through this start cross-sex hormones already having lower bone density. This sets them up for osteoporosis later, a higher risk of fractures, chronic pain in their muscles and bones. It's compromising the body's basic structure.
Okay, so beyond fertility and bone density, what about the long-term risks of the cross-sex hormones themselves? Let's start with MTF hormones of the cross-sex hormones themselves. Let's start with MTF hormones, biological males taking estrogen, maybe anti-androgens like spironolactone.
Right. The goal is feminization. Less muscle, stopping facial hair, maybe some breast growth.
But the side effects listed in the sources sound really serious.
They are. The risk profile includes dramatic strokes, type 2 diabetes, certain cancers, and as we just mentioned, that later life osteoporosis.
Are there specific numbers on this?
Yes, and they're quite stark. One large study followed 303 MTF individuals. It found a massive 45-fold increase in blood clots, specifically things like DVT, deep vein thrombosis, and pulmonary embolisms.
45 times higher?
Compared to who?
Compared to the general population baseline used in that study? It's an enormous increase in risk. And that same study noted a 15-fold increase in depressive mood changes.
15-fold for depression, 45-fold for blood clots. That DVT, pulmonary embolism, those can be fatal, right?
Absolutely. A DVT is a clot, often in the leg. If it breaks off and travels to the lungs, that's a pulmonary embolism, and it's a medical emergency. Life-threatening.
Do the sources explain why the risk is so high?
They link it directly to the high-dose synthetic estrogens often used, particularly one called ethinylestradiol. It's been known for a long time that it increases clotting factors in the blood. And this risk can be even higher if the person has other risk factors, like maybe they're overweight or they smoke. It just amplifies the danger to their vascular system. It makes it less abstract when you hear personal stories. The sources included an account from Jamie Shoup, who transitioned and later detransitioned, talked about the physical toll of these drugs.
Yeah, Shoup's account is very detailed. Mentioned taking spironolactone, the anti-androgen. Because it's a diuretic, it caused intense cravings for salt, chronic leg pain, and needing to pee constantly, urgently.
How often?
Shoup reported that's disruptive, to say the least.
Wow. And that was just the spironolactone.
Right. Then Shoup switched to high-dose estrogen and developed chronic leg pain and swelling. It got so bad they ended up in the emergency room because doctors were worried about a blood clot, exactly the risk the data warns about.
So these aren't rare freak side effects.
Now, they're known pharmacological risks, need constant medical monitoring, and they can really impact quality of life.
Yeah.
You're essentially managing a drug regimen that carries severe cardiovascular risk just to maintain the transitioned appearance.
Okay, let's switch gears. What about FTM hormones? Biological females taking high doses of testosterone, basically anabolic steroids, right?
Essentially, yes. And this brings a different set, but equally significant, of permanent changes and systemic risks.
Permanent changes.
A permanently deeper voice. Often quite significant facial hair growth that needs lifelong management like shaving or electrolysis. Often male pattern baldness. Severe acne can be a big issue too. And these things don't reverse even if someone stops taking testosterone.
Irreversible. And the systemic side effects.
Beyond the likely sterility, the sources mention reports of sort of a ongoing feeling of mild depression or lethargy, a sense described by some people that their body is just aging or wearing out faster than it should. It's possibly due to the chronic stress on the body, the liver, the cardiovascular system from constantly processing high levels of these anabolic hormones.
And the mental health side of high-dose steroids. We hear about roid rage sometimes. What does the data say about mood and psychosis?
The data is worrying. Sources cite findings that nearly a quarter, maybe 20% of patients on high-dose anabolic steroids, like the testosterone used in FTM transition, show major mood symptoms.
Like what kind of symptoms?
Severe mood swings, irritability, agitation, even aggression. And beyond that, a significant minority, somewhere between 3 and 12%, actually develop clear symptoms of psychosis, psychiatric help.
So it's not just physical changes, it's chemical disruption of the brain too.
It's a documented risk, yes.
Okay, this brings us to maybe the most critical systemic risk, lifespan. You highlighted a finding that long-term, lifelong use of these synthetic hormones shortens lives.
Unequivocally, yes. The sources link these therapies directly. Pulmonary embolisms, bone damage, liver failure, kidney failure. There's a clear long-term toll.
And is there data on how much it might shorten life?
Well, looking at older groups who transitioned decades ago gives us some insight. The sources suggest an inference based on that data that people who transition and stay on hormones for life might see their lives shortened by roughly 25 years compared to the general population.
25 years, that's staggering.
It's a massive potential reduction in lifespan. It seems to be a direct consequence of the chronic chemical intervention needed to maintain that cross-sex body chemistry. It shows the biological cost is really, really severe.
Okay, so if the hormones carry these lifelong systemic risks, the surgery side seems to be about massive acute risks and often chronic failures. This is where that 40 to 60% complication rate figure comes in, right?
Exactly. And we need to really let that sink in. 40 to 60% complications for elective surgery is incredibly high.
How high compared to other surgeries?
Astronomically high. Most elective surgeries aim for complication rates in the low single digits, ideally under 5%.
Right.
To put the 40-60% into perspective, the sources note it's not unusual for someone to need 6, 7, even up to 10 operations over many years, either to complete the initial transition steps or, very often, to manage the constant complications and failures of the reconstructions. And think about it that many surgeries means multiple times under general anesthesia, which has its own risks. It leads to long-term issues like chronic pain, incontinence, even DVT just from repeated procedures.
Okay, let's break down these high rates for specific surgeries. Starting with vaginoplasty for MTF patients. That's creating a neovagina, usually using penile inversion or maybe an intestinal graft.
Correct. And the reported complication rate, just for this 1%, still very high.
What kind of complications are we talking about? Can you define the terms?
Sure. Physically, you see things like wound dehiscence. That's where the surgical cut splits open. Happens in 5 to 15% of cases. Infections are pretty common, maybe up to 10%. And then there are more severe things like rectovaginal fistulas. That's in 2 to 5%.
Fistula. What exactly is that in this context?
It's basically an abnormal tunnel or passage that forms between the newly created vagina and the rectum next to it. It might happen if tissue breaks down or there's a surgical error.
And the consequences?
It almost guarantees chronic infections, leakage of stool into the vagina. It's devastating to fix, often unsuccessfully.
Okay, those are the acute problems. What about ongoing chronic issues?
They're common too. Chronic pain, often nerve-related, affects 10 to 20% of patients. And a really significant one is neovaginal stenosis. It means the surgically created vaginal cavity starts to narrow and contract, basically closing up. This happens in 10 to 15% of cases.
Can that be prevented?
It requires lifelong, usually daily, dilation, using medical dilators to physically keep the canal open. If they stop, it can close completely, needing more surgery just to maintain it.
Lifelong daily dilation. And functionally, quality of life.
Also significantly impacted. Urinary problems are frequent. Actual incontinence, leaking urine, in 5 to 10%. And urethral strictures, where the urinary tube narrows, making it hard to pee, in about 7%.
And sexual function.
That's a major issue for satisfaction. The sources say 20 to 30% report inadequate sensation, or critically, they just can't achieve orgasm after the surgery.
Wow. Okay, so that's vaginoplasty. The sources suggest phalloplasty for FTM patients is even more complex and risky.
Arguably, yes. It's probably the most technically demanding procedure in this whole, usually using tissue transplanted from the forearm or thigh, connecting tiny blood vessels and nerves microsurgically.
And the complication rate reflects that complexity.
It does. It jumps up to that 40 to 60% range we mentioned earlier.
Why so high? What goes wrong?
Because it's microvascular surgery, trying to get this transferred tissue flap to survive. Common failures include urethral fistulous holes forming in the new urinary tube. That happens in a staggering 20 to 30%.
A quarter of patients getting leaks in the urethra.
Roughly, yes.
Yeah.
And urethral strictures, The narrowing happen in 10 to 20%. These issues almost guarantee multiple follow-up surgeries just to try and get urination working.
Just failing the transplanted tissue.
That's called flap necrosis. The tissue dies because it doesn't get enough blood supply. Happens in 5 to 10% of cases.
And then what?
It has to be completely removed. It can risk amputation if infection sets in badly. And it leaves a huge, very visible scar where the tissue was taken from, often the forearm. Well, the surgery has failed completely.
Even if the flap survives, what about function?
Functionality is a huge challenge. Erectile function usually requires implants like rods or pumps. These have mechanical problems or get infected in 20 to 40% of cases. So a large minority lose that function soon after getting it.
And sensation.
Very limited. Only about soon after getting it.
And sensation.
Very limited. Only about 60 to 70% achieve some kind of tactile response, like feeling touch. And urinary spraying, instead of a stream, affects 15 to 25%.
This sounds incredibly difficult, physically and emotionally.
It is. The sources really emphasize the psychological toll.
Yeah.
The high chance you'll need more surgeries, the incredibly long recovery time, 12 to 18 months often.
A year and a half?
Yeah, potentially. All this contributes significantly to anxiety, depression, and even documented regret. They end up trading their initial dysphoria for a kind of chronic surgical distress.
We should probably touch on mastectomy too, top surgery for FTM.
Still significant risks, yes. The complication rate is lower, maybe 10 to 20%. Common issues are things like hematomas, internal bleeding collecting, or seromas fluid buildup. Both often need draining.
Okay. Anything more serious?
Nipple necrosis is a risk, maybe 1 to 3%. That's where the nipple grafts, if used, die and fall off. That's aesthetically devastating for many. A major issue. 30 to 50%, so up to half, experience permanent loss of nipple sensation. That can really impact body image and intimacy. Chest contour irregularities like bumps or dents also occur in 10 to 15%.
These percentages are stark, but the Scott and Nugent story provided.
In 10 to 15%.
These percentages are stark, but the Scott and Nugent story provided really brings it home.
It really does. It makes the data horribly real. Nugent, who transitioned FTM, described a journey of 7 surgeries, suffered a massive pulmonary embolism, a blood clot in the lung, a heart attack brought on by stroke.
7 surgeries. And the complications just kept coming.
Yes, what's devastating is the chronic failure. Nugent talked about a recurring infection that lasted 17 months. It started because the surgeons apparently used the wrong type of skin graft during a phalloplasty attempt.
17 months of infection.
Requiring 16 rounds of antibiotics, just imagine.
The physical trauma list just intense. Permanent lung and heart damage, a cut bladder during one surgery, hallucinations from lack of sleep, passing out from pain.
And that specific detail about hair growing inside the reconstructed urethra.
Yeah, what causes that?
It's a known complication when skin grafts containing hair follicles are used for the urethra. The hair keeps growing inside, causing chronic infections and intense pain when urinating.
The end result for Nugent.
PTSD so severe they were housebound for a year, and total medical bills just for dealing with the complications topped $900,000.
$900,000. That one story just encapsulates the potential for catastrophic failure within those 4.
It's a human face on the statistics, absolutely. A horrific one.
Okay, these risks are already immense, but applying them to minors, to adolescents, that adds a whole layer of ethical complexity, doesn't it?
Exponentially more complex. And the sources do document a trend among some doctors pushing to lower the age for starting these irreversible medical steps.
Why lower the age?
Interestingly, it's often driven by technical surgical considerations, not just psychological readiness. For biological males wanting vaginoplasty later, the penis needs to have reached a certain size from puberty first, so there can be pressure not to block puberty too early or to start hormones sooner.
Okay.
And for biological females, there's sometimes pressure to start testosterone before significant breast growth happens because it makes the eventual mastectomy technically simpler.
So starting testosterone at 12 or even younger?
It's happening according to the sources, and this immediately raises that critical question. How can a 12-year-old possibly grasp the lifelong implications we've just discussed? The potential $900,000 trauma, the 25 years shorter lifespan, the chronic pain, sterility.
It seems impossible, and one specific long-term issue for young people seems particularly stark: the loss of sexual function, especially for biological males.
Like Dr. Marcy Bowers, who is highly respected and performs many vaginoplasties, have expressed really profound concerns about this.
What did Dr. Bowers say?
Specifically, that if puberty is fully blocked and the person has never experienced orgasm naturally before surgery, it becomes very, very difficult, maybe functionally impossible to achieve orgasm afterwards.
Why is that?
Because the functionally impossible to achieve orgasm afterwards.
Why is that?
Because the natural development during puberty, driven by testosterone and estrogen, is crucial for maturing the nerve endings and structures needed for sexual sensation and response. If that development never happens.
The wiring isn't there, basically.
That's a good way to put it. Dr. Bauer's cases as potentially feeling like it might as well be a fingertip, bringing no particular joy.
Wow.
And this obviously impacts long-term happiness, romantic relationships. Dr. Bauer's observed it leads to broken relationships because the individual simply cannot respond sexually. It's sacrificing potential adult sexual function.
This really leads us to the question of long-term mental health, because the whole point of transition is often stated as improving mental well-being, right?
That's the stated goal, yes. But the data often shows a contradiction.
How?
That research from Sweden is really crucial here. It followed people long-term after sex reassignment surgery, and it found they had considerably higher risks for mortality, suicidal behavior, and psychiatric morbidity compared to the general population.
Higher risks after surgery.
Yes, years after. This suggests that either the underlying mental health struggles weren't resolved by the physical changes, or perhaps new issues arose related to the chronic physical problems, the complications, the ongoing medical needs.
So surgery didn't necessarily fix the underlying distress. It might even add new layers of distress.
That appears to be the case based on that long-term data. And adding to that, there's an observation noted within the trans community itself, sometimes called the 7 to 10 year trans suicide itch.
What is
7 to 10 year trans suicide itch?
What does that refer to?
It describes a period often many years after the initial transition, maybe after the initial relief or euphoria wears off. The daily reality sets in the chronic health issues, maybe surgical regrets, the hormone dependence, the impact on relationships, and turn sometimes stronger than before.
That's deeply concerning. It makes you think about the possibility of alternatives.
Well, and the source material does mention that many young people who explored a transgender identity for a time eventually desisted. They changed their minds, maybe found peace with their biological sex through therapy, or just matured and learned their biological sex through therapy, or just matured and learned to manage the feelings of dysphoria without medical intervention.
Which really underlines the need for caution before irreversible steps are taken with developing adolescents.
Absolutely. And for parents who are in that incredibly difficult situation, with a child pushing for transition, maybe expressing distress, the sources offer some direct guidance, particularly around suicidal threats.
What's the advice there?
Essentially, parents are advised not to feel they have to decide on permanent medical transition for their child. The consequences are just too vast and lifelong. If a child threatens suicide, and the sources note this might sometimes involve language learned online, a sort of script. The advice is to treat it first and foremost as a psychiatric emergency, meaning take the child to the hospital immediately. Get treatment for the suicidal thinking itself. Separate that acute crisis from the longer-term question of gender identity and transition. The priority has to be keeping the child safe and pushing into irreversible physical changes under duress. Okay, the last piece of this puzzle we need to look at is the economic side. The cost, the value for money, as presented in the sources.
Right, because these interventions are expensive.
Extremely. And when you factor in those sky-high complication rates, 40 to 60%, plus the documented cases of regret, the need for care for hormones, potential revisions, the sources basically argue that from a public health perspective, we might not be getting good value for the money spent on these high-cost transition pathways.
It's not just the initial surgery costs, like the $900,000 Scott Nugent ended up with due to complications. It's the lifetime burden.
Exactly. Years later, treating the heart problems or mental health issues that might arise or worsen because of the transition process itself, it all adds up.
So what's suggested as potentially more cost-effective?
The sources specifically point to early and ongoing intensive counseling or psychotherapy. The argument is that this approach could potentially save hundreds of thousands of dollars per person compared to the full medical route,
while also addressing the root causes.
While focusing on understanding the underlying causes of the dysphoria and critically minimizing the risk of severe physical harm. So the suggestion is that shifting policy towards more robust psychological support first, based on the evidence of poor long-term efficacy, and high risks for surgery, could be better for both health outcomes and be more financially responsible.
Okay, so let's try to pull this all together. Synthesize the main threads we've followed today from the sources. What are the absolute key takeaways for someone listening?
I think there are three big ones.
Ways for someone listening.
I think there are three big ones. First, that fundamental lack of robust scientific evidence showing gender reassignment surgery itself is clinically effective in the long run for improving mental health outcomes.
Right. Foundational uncertainty.
Second, the massive and unavoidable systemic risks from lifelong hormone use. We're talking that 45-fold higher risk of blood clots for MTF individuals, the certainty of becoming sterile, the significant risk of psychosis for FTM individuals on testosterone, and that chilling inference of potentially losing up to 25 years of lifespan due to the chronic stress on the body.
Huge systemic risks. And third,
The surgical reality. 60% for major procedures like phalloplasty, often leading to years of repeated surgeries, physical trauma, chronic pain, loss of function, and sometimes, as we saw with Scott Nugent, just catastrophic financial and personal cost. Hashtag outro paper.
we have definitely covered a lot of ground today, and it's heavy stuff. We've stuck strictly to the data and accounts provided in your source material. Just to hammer home those key specifics for you, the listener, remember that 45-fold increase in blood clot risk for MTF hormone users. Remember the 40 to 60% surgical complication rate, sometimes needing 10 or more corrective surgeries. Think about the near certainty of sterility. And the serious concerns about losing lifelong sexual function, especially for minors who transition early. And remember that persistent finding of higher mortality and suicidal behavior rates after surgery compared to the general population. This isn't simple information. It really demands careful thought.
It really does. And perhaps beyond that source material, here's a final thought for you to consider as you process all this. Given those specific data points about long-term mental health outcomes and that anecdotal but recognized pattern of the 7 to 10-year trans suicide itch, that resurgence of distress years later, how should doctors and maybe society weigh the immediate relief for someone in distress right now against the documented potential for intensified psychological and physical suffering years down the line?
That's a tough balance.
It's incredibly tough. And that question becomes even more critical, perhaps, when we're talking about making these life-altering, irreversible decisions based on the emotional pain, which we know is still changing rapidly. It's a vital consideration.